And yeah. So ma'am comes with a vast years of experience in clinical, both in clinical and teaching. So with further no delay, I'm just taking you all through this particular case scenario. First, we'll understand what exactly had happened to this particular kid, and then we will also have I'll push this particular pattern to Madam Sonali Jadhav, our moderator, and she will take it from there. Give me a moment, and this is the description of our 10-year-old boy, Mr. Arab, sorry, Master Arab, who started his journey with a playful kid who was actually going to school. And one particular day, this particular boy had a unsettled fever, which was kindly progressing. Worsening fatigue was there, and loss of appetite, and unexplained weight loss, frequent gum bleeding, easy bruising, and intermittent bone pain. So this was his basic presentation at at start. And the parents had taken the kid to the hospital, and on clinical examination he appeared very pale with visible petechial rashes over his lower limb and mild enlargement of liver and spleen. So his initial blood investigation revealed severe anemia, thrombocytopenia, and marked elevated white blood cell counts with circulating blast. Peripheral smear and subsequent bone marrow aspiration confirmed the diagnosis of acute myeloid leukemia with more than 30% of myeloblast. So immunophenotyping established the AML subtype, and cytogenetic analysis categorized it as an intermediate risk disease. So the diagnosis was very, very devastating for the family. And Arav, the name is changed of this particular patient, was admitted immediately, and after platelet transfusion support, a central venous catheter was placed to initiate intensive therapy. So basically, it started with the first admission and induction phase started. So that is called to be fighting for the first remission we are trying to talk about. So where this particular kid was started with an induction chemotherapy using 7+3 regime comprising of cytarabine for 7 days and daunorubicin for 3 days. As expected with intensive chemotherapy, he developed complications during this phase. It was expected though. Around day 10, he developed febrile neutropenia and blood culture grew Klebsiella pneumonia. Prompt intimation of initiation of broad spectrum intravenous antibiotics help control the infection. He also developed grade 2 oral mucositis, which made eating painful and required temporary intravenous fluid and short-term parenteral nutrition. Multiple packed red blood cells and platelet transfusions were needed to support him through marrow suppression. Despite these setbacks, RF demonstrated remarkable resilience. More power to this kid. At the end of induction, day 28, bone marrow examination showed morphologically remission. The family experienced a smile and complete remission was achieved. Slowly, what happened? The consolidation or unexpected relapse happened. And over next several months, Arav underwent 2 cycles of consolidation chemotherapy aimed at deepening remission and preventing relapse. This period was marked by recurrent neutropenic attacks and 1 episode of central line associated infection, which required line removal and antibiotic therapy too. Prolonged hospital visit, treatment, fatigue, and absence from school began to affect him emotionally also. Approximately 9 months after initial diagnosis, RF again presented with fever, bone pain, and falling platelet counts. Bone marrow examination confirmed the family worst fear, that is relapse AML. This phase was emotionally overwhelming. The oncology team discussed the bone, tumor board and the need for treatment, intensification, and the role of bone marrow transplantation. Now it is called a stem cell transplant as potentially curative option. So idea of transplant took up, and a salvage therapy and preparing for transplant started up, and RF received salvage chemotherapy, following which he achieved a second remission. HLA typing was identified with his younger sister as a fully matched sibling donor, offering a strong chance for successful transplantation. Extensive counseling sessions were conducted with the family to discuss transplant risk, including severe infection, graft versus host disease, GVHD, and the need for long-term follow-up. Both Arav and his sister showed extraordinary and extremely courageous character and the nature during donor evaluation and transplant preparation. So it was a day when it came to bone marrow transplantation and acute recovery. So at approximately 12 months from the diagnosis, Arav underwent a allogenic hemopoietic stem cell transplant following a myeloablative conditioning regime using high-dose chemotherapy. On transplant day, that is day zero, stem cells were infused without any immediate adverse reaction. The early post-transplant period was challenging between day +5 and day +15. Arav experienced profound neutropenia. On day +7, he developed fever with a strong suspicion of fungal infection and was started on empirical antifungal therapy. He also developed mild acute skin GVHD grade 1, graft versus host disease, which was successfully managed with topical steroids and systemic immunosuppression or suppressants. Early imbalances required electrolyte infusions or corrections, closed and continuous monitoring. Engraftment occurred gradually. Neutrophils recovered by day +16 and platelet recovery by day +22, making a critical turning point in his recovery. With all great hopes, discharge and the first step to back home, he took his first step out of the hospital after nearly 6 weeks of hospitalization. Ara was discharged home happily on oral immunosuppressants and antimicrobial prophylaxis. His family was educated extensively on infection prevention, medication adherence, and warning signs requiring urgent medical attention. The first day at home was deeply emotional, relief with anxiety. So, with this, the baby is still on follow-up, and he's still, on a journey of his survivorship, and he's counting his milestones of survivorship. So, with this particular overall insight of the case scenario, I'm passing the baton to Madam Sonali to take up this particular discussion with different team of panel members who have connected here to understand how best and what best we can do in such situations with some pediatric patients coming up like this who are going to stay with us long term, understanding the impact which creates on the baby's emotional and psychological well-being, as well the parents too. Over to Sonali, ma'am.
Good evening. Thank you, Diane, for the very insightful and a detailed description of case of Master Arav. Let me introduce our today's panel. Our panel is going to talk to us. We're going to have questions posed to them about a similar case like what Arav went through, and we would have their expert opinions today. So let me introduce our panel to the audience for today's discussion. We have Mrs. Chandrakala, the CNO of Gleneagles BGS Hospitals from Bangalore. We have welcome Chandrakala. We have Anisha Nishu, who's a junior nurse from chemotherapy department from Manipal Hospitals as our panelist. We also have Shayantika Bera, who is a staff nurse from BMT department, again from Gleneagles Hospital. We have Dr. Priyank Tripathi from Manipal Hospital, who is a clinical pharmacist with 13 years of experience. Thank you for joining us, Dr. Priyank Tripathi. And we have a senior nursing administrator, Mrs. Shaini Burgess, who is head of nursing at Manipal Hospitals with over 25 years of experience to her credit. So a warm welcome to our multidisciplinary expert panel for this evening. To begin with, as we heard from Abdul, infection is one of the most critical problem that can happen in patients like Master Ara who are on chemotherapy and also immunosuppressive medication. So, Chandrakala, my first question to you is, when Arav developed febrile neutropenia during the induction period, what do you think which are the most critical moments moments in his care carry the highest infection risk, and how as nurse that can be prevented?
Yes, ma'am. Thank you for the question, ma'am. So here in arrow case, the most dangerous window period, window periods were when multiple risk factors overlap. So first thing we can say central venous catheter access.
Mm.
Handling central catheter multiple times. It can be like blood sampling, blood transfusion, IV medications, like handling multiple times. That could be one of the reasons. And also changing the dressing of central line. That is also one of the reasons. Might be this is all like chances of highest infection risk. And also the one more common complication in BMT patients is mucositis, breach in oral mucosal barriers, allowing bacterial transmission. This is also one of the most highest infection risks. And also environmental factors. Visitors, so since we have to, baby is 10 years old, we have to allow parents or like one attendant, we have to allow along with the patient. This is also one of the reasons for the infection. And also infection risk is not a single moment. It is cumulative and peaks when immunity, barriers, and device all together fall simultaneously. So this is all maybe could be the reason for highest infection risk for this patient.
So thank you for that answer, Chandrakala. What the audience understands that all kinds of invasive procedures, mucositis, certain environmental factor could pose a risk of infection for a patient like this, Master Ara, what we're discussing. Going to Anisha. Anisha is working as a chemotherapy nurse in her department. So, and she's the junior most nurse we have here. Anisha, we discussed in this case that the patient had a neutropenia and he was to be administered chemotherapy. So, what mistakes generally junior nurses are most afraid to admit in oncology department when they are with their patients, like you, junior nurses, when they are working, and what happens to patient safety when fear replaces communication? What would you like to say about it?
Thank you for the question, ma'am. So for a junior nurse, the fear of reporting an error can take place. So even when we are about to administer the medication, even if we have a doubt, we can clarify with the senior consultant or the seniors, whomever we have in the department. So as a nurse and lifesaver, admit the errors and escalate immediately to save the life of the patient. That should be the immediate action taken by the junior nurses to avoid the errors, ma'am.
Okay, so prevention of errors is one thing that we should focus on. And in case of an error happens, what a junior nurse should do?
We has to immediately escalate to the higher authority, like our senior staff, the consultant, to prevent the further complication that leading to the patient to harmful toxicity.
Absolutely. So junior nurse should not be afraid of reporting the
Yes,
error
ma'am.
that has already taken place. Of course, prevention can be done by learning the procedures correctly or having the supervisors supervise you while you do it initially. Thank you for that, Anisha. Coming to you, Shayantika. In the immediate post BMT period, as we heard from Arav's case, that he was profoundly neutropenic. What are the three top nursing priorities on every shift for such a patient that a nurse should have?
Thank you, ma'am, for the question. Actually, post BMT neutropenia, we have to focus on infection. Every hourly, we have to monitor the vitals when patient is unstable. Then fever is equal to emergency that time. Then we have to maintain the strict aseptic technique, like always hand washing before entering the patient's room, then always wearing the gloves and using hand rub before touching the central line. Patient can get infection because their immunity will be very low in that time. Then you have to monitor the electrolytes and fluid and organ monitor also, because before transplant we will be giving very high dose of chemotherapy that can cause the nephrotoxicity. So we have to monitor renal function also along with that electrolytes also. And another thing is medication, cyclosporin, which we have to send like every 2 or 3 days sample to monitor it is increased or decreased. Based on that, we will maintain the dose of that injection, which will prevent the organ rejection.
Okay. And as a nurse, what would you like to speak about the diet and intake of this patient and environmental factors?
Yes, ma'am. We have to use the HEPA filter room, like positive pressure. Then about food, all BMT patients should take neutropenic food. No outside food. It should be freshly cooked food and no fruits. Some fruits we can allow, but not all the fruits. Which fruit we can give? That is like that skin will be very thick. Like that, any fruits we can give, but consultant should give that permission then only. And another thing, always we have to give the hot food. Have to microwaves, and after that only we can give the foods.
Okay. So thank you, Shayantika. We have a clinical pharmacist, Mr. Priyank Tripathi, joining us. As we heard in Arav's case, Arav was receiving a broad spectrum antibiotic, antifungals, and several other drugs. And polypharmacy is something sometimes very common in oncology patients. And of course, there is a risk of drug interactions and toxicities. Dr. Tripathi, we would like to know from you as a clinical pharmacist, your advice will be to the nurses that how can they prevent these drug interactions in first place, or in case if they occur, how do they recognize them at the earliest possible and what to do next?
Good evening, ma'am. First of all, thank you for inviting me here. It's indeed an honor. So, in terms of what precautions that we should take and what kind of interactions that we need to be careful about during a bone marrow transplant, specifically in this particular child's case, uh, since it is a relapse transplant, there will be and the child has received myeloablative, preparatory regimen, which essentially causes pancytopenia. Uh, so what's important here is to first thing to look at what myeloablative treatment drugs that we are using, whether it is fludarabine, cyclophosphamide, it is busulfan, fludarabine, or what drugs are being used. Two of these drugs would be the choice of treatment that usually are given these days for the bone marrow suppression. Now, along with this, there are a few precautions. Those are important. I understand that we need to focus on interactions, but when we are looking at interactions and impact of interactions, it is important, I believe, for all of us together as a team. What can happen, right? Now, we also looked at mucositis. One thing that is proven very effective, and this can be because of drug interaction. This can be because of the drug on its own without any apparent and obvious interaction. If you're using alkylating agent, so to simplify, when I say alkylating agents, if you're using busulfan or melphalan, one very simple way to prevent mucositis or reduce the risk of mucositis is to give cryotherapy. When I say cryotherapy, a few chips of ice, right? We just give the patient a small ice cube for them to let it dissolve in their mouth. That keeps the temperature low, and with that low temperature, the blood supply to the mucosa is low. So what happens? The Since the less of the drug is reaching the soft tissue, the risk of mucositis comes down. So one thing that that we practice, especially when you are using high dose therapy, uh, is to give cryotherapy. Now, coming on to one of the preventive way to prevent mucositis. Now, coming on to the drug interactions, the kid has been on, kid required because of the severe neutropenia. The kid required antibiotics. I'm sure the kid must be on, immunosuppressants, uh, steroids as part of the immunosuppressant protocol or otherwise as well. This essentially something which is which you cannot avoid. Polypharmacy in situations like this is something that you cannot avoid. Now, what are the drugs that may interact with each other? Of course, the the immunosuppressants, whether you use tacrolimus, you use cyclosporin, or you use mycophenolate mofetil, which we also call as MMF. One of two of these drugs or one of these drugs is something that you'll be using. And when you're using these drugs on its own has very high potential or risk of causing interactions. Other thing is because the child is also on steroids. Steroids can alter, the levels and cause and lead to drug interactions with these drugs. Easiest way and the safest way to practice, is to, one of our co-panelists was mentioning about it, is to do therapeutic drug monitoring. When I say therapeutic drug monitoring, every 72 hours or every 48 hours, depending upon your institutional protocol and depending upon the dose of the drug that you have given, we look at the serum concentration or the blood concentration, of that particular drug, especially in case of immunosuppressant. So looking at that level, you get to know whether your drug is more than the level that is required for the patient or below the level that is required for the patient. That is purely based on the calculation. The point is, as a first responder, moment you see it, moment you receive the report, first thing first, learn yourself about it, know what you are looking at. To escalate or discuss immediately with your clinician and your CP, whoever is responsible for the patient's care, so that you can take actions immediately.
Okay.
Because in these circumstances, since these drugs are low, narrow therapeutic index, immediate actions are always required.
So the key points what Dr. Tripathi has told us how to prevent mucositis for the patients. Second thing we learned from him as to how to monitor the therapeutic levels of the drugs and escalate the matter in case the therapeutic levels are altered to the physician of the patient so that the patient does not get harm. And you also mentioned the drugs that are most interactive with each other, that nurses should be careful while administering those. Am I right, Dr. Tripathi?
Absolutely, ma'am. I think one drug that I'm missing over here, a couple of drugs that I'm missing over here, are antivirals in general, whatever antiviral you use in your hospital, and the antifungal. It can be, as safe as posaconazole, but at certain high dosages and with drugs like, cyclosporin, tacrolimus being there, the risk of interaction is very high. So whenever you see these drugs being there, steroids, just to name a few, when you see steroids, the antifungals like posaconazole, fluconazole, etc. The high dose chemotherapy, very high dose chemotherapy. Stay alert and make sure that you ask the question to your physician and your CP around to ensure that a defined gap is given.
Thank you. So I'm sure the audience had a very important points to take away from Dr. Tripathi's talk. Coming back to you, Anisha, like Dr. Tripathi talked, and we heard in Arav's case initially when the chemotherapy was started, although it is recommended that in children chemotherapy should be administered through central lines or PICC lines or port, Arav had a peripheral line, and we had to administer initially maybe until he had a port through the peripheral line chemotherapy. What according to you care nurse should exercise while using peripheral lines to administer chemotherapeutic drugs?
That is a really good question, ma'am. The responsibility of a nurse is to monitor the IV peripheral line during the infusion of any Vasecan drug. As we know, Ara was receiving danorubicin injection medicine in the initial state. That is a vasovasecan drug. So there is a minute displacement of the catheter can cause extravasation. So that may lead to further complications. So as a nurse, we should be monitoring the IV lines during the injection infusion. So that we can prevent any kind of toxicity, like preventing IV line extravasation to the patient.
Thank you for that, Anisha. Coming back to you, Sayantika, you had the patient Master Ara, who also developed mild acute graft versus host disease. How, as a nurse, one can identify symptoms of this graft versus host disease early and report them to the physician?
Thank you for the question, ma'am. Actually, we can identify like patient can get skin rashes, then like skin tenderness will be there, skin will be warm, some itching can happen, and the patient will lose the appetite, and some bowel pattern changes will be there. Then we have to monitor the bilirubin level. It is a very high chance to increase the bilirubin. And
Okay.
another thing is we have to monitor the weight gain. Patient will gain the weight. So this primary symptoms we can identify like GVHD is happening.
Okay, thank you, Shantani. I think she's given a very much clarity as to what are the early symptoms of GVHD and how to identify them. Coming back to you, Chandrakala, with the neutropenic RAV, we probably had to care for RAV in isolation setup. And I would like to ask you that how do you follow the strict isolation rules and explain these to the family? While supporting the child's well-being, especially when the patient is young, like this.
Yes, ma'am.
Yeah.
Very important questions in BMT patient handling.
Mm.
Isolation precaution is one of the important infection prevention among all precautions. So, which is very very important. So that we have to place the patient in isolation room, that to
Mm.
positive isolation room, where
Mm.
only patient will be there and one allocated nurse will be there. It's very difficult patients to say, like when it comes to this baby thing, it is very difficult placing 10-year-old baby in one single room only with one nurse. So now
Mm.
how we have to convince the patient and patient attender? It is very, very important. First thing, we have to explain patient and patient family what is the importance of isolation room. Why
Mm.
we have to take them, then definitely they will understand and they will agree for that. So while explaining, we have to explain them in their understanding languages. That is very important. How isolating the patient is important. How like if we mix the patient with other patient, how infection will spread to the baby. If we separate, how we can prevent. So definitely parents will agree for this. That is one thing. We have to counsel them. We have to convince them. We have to explain them importance of isolation. So when it comes to second point, uh, and also we have to tell them it is a protection, not the punishment. The
Mm.
third thing, and we have to entertain some of the environmental factor, like allowing parents, like one parent we can allow with the following all the infection control practices. So we can allow one caregiver with the patient, and also we can create some good environment where baby can arranging the audio video calls or some play therapy inside the isolation room. So this is all we can create, so that we can ensure baby is in isolation room, so that we can prevent the infection. We can prevent infection, and also we can explain. We can take the consent from the family, so that we are placing patients in isolation room.
Thank you, Chandrakala, for bringing out these very important points that would not just take care of protecting the patient, but also it's his emotional well-being, patients as well as families. We have Mrs. Shiny, who is the nurse administrator, and we have seen Mrs. Shiny. The journey of this patient is long, with having chemotherapy, then a relapse, then BMT, and post-discharge, and then follow-up. How does nursing administration ensure continuity of care when a child transits like this in a hospital care setup?
Right. Thank you for that question, ma'am. I
Mm.
would rather say it is twofold.
Mm.
The import, like improve the care quality
Mm.
and then enhance the patient care. How do you improve the care quality? Develop a protocol, educate the staff, monitor the care quality to prevent complications and improve outcomes. Coming to enhance patient care, have a patient-centric approach.
Mm.
Education and support of the family is very important. Counseling,
Mm.
and that would promote a positive attitude and environment,
Mm.
and also promote the collaboration among the caregivers.
Okay.
So these two things definitely ensures the care.
Thank you. Thank you for that. And we also talked, Mrs. Shiny, about, in case if a junior nurse creates a error or something. So, with that regard, how are root cause analysis findings from infection events or other any kind of events that happen? They can be translated into sustained system level changes.
Yeah, this errors could happen maybe, the adherence, treatment non-adherence, including medications or a follow-up of appointments, or infections or other complications can lead into, can be, led to treatment delays. Sometimes graft versus host diseases can delay the recovery and also increase the risk of relapses. So I would say close monitoring, personalized treatment, adherence to treatment, and infection prevention are the key cornerstone in preventing all these things.
Okay. So thank you. We have for this round the last question going to you, Mr. Tripathi. That these patients, like in Arav's case, we saw he had to go home and be on medications and probably come for follow-up visits. So, what do you see a clinical pharmacist as well as nurses' role in educating parents so that they can, adhere to the treatment regimen at home and also have a better understanding of it?
I would rather add one more, important member of the treating team here, the physician. Um, you know, uh, it's important that as a team, a physician, nurses, pharmacist, all category pharmacists, whether it is a hospital pharmacist or a clinical pharmacist, act as a team in situations like this, especially when you are, dealing with pediatrics. Child of these ages, if they are able to swallow tablets or capsules on their own, things are rather easy. But we do come across situations when the kids are not very well versed with swallowing of tablets and capsules, right? In those situations, at the hospital, since we all are trained, we all know how to, prepare exemplarious preparations out of, tablets and capsule, either crushing it or dissolving it, whatever is the right way for that particular formulation. We do it and give it to the patient. Now, important thing, as you rightly mentioned, is at home. Now at home, whether the family understood if it is a capsule, say for example, cyclosporin capsule. Now whether the family understood how to open the capsule safely, how to take the content out of it, what are the fluids that I can use, to make a small suspension or a syrup out of it. That's important, because if they're not been able to take the complete drug out, or if they have not used a fluid which is compatible with the drug or the powder, I mean, the whole effort of, despite of giving the drug, we might not be achieving the desired results, because the fluid used is not compatible. The drug inside will not remain viable to the limit that we want the drug to. So it's important that we try to understand the minor aspects of care, especially at home. When they are under our supervision, most of it is taken care. But when they are at home, it's important that we counsel them. It's important that we give a written instruction of how to do things. It's important, the drug preparations, the precautions that they have to take, every single thing. It's important that they read it, they understand it, and they tell you back. It's important that we ask them to demonstrate in front of you. Fine, if they have to prepare, it's okay. If one dose gets wasted, it's absolutely fine, right? Ask in front of you. Let them prepare the solution in front of you, right? That's the best, because when you teach them, they may presume that they have understood it. Point is, after 7 8 hours, 12 hours, when they are at home, how much will they remember? So to give a handout, important, if we are giving drugs which can interact, to make them understand that they have to avoid milk or certain foods in and around their drug, to make them understand how to safely give the drug.
Right,
And
right.
most importantly and last, which often get missed, is if the patient is on a drug which require therapeutic drug monitoring. These patients will be on immunosuppressants for
Right,
longer
right.
time, right? It is important that they give the samples on time.
Yeah.
First 1 month is very, very critical,
Yeah.
right? If we are able to establish the proper drug dosing for first 1 month, we have,
Yeah.
we have captured. So
Mm.
it's important that they follow all
Mm.
this with that.
So if you have to paraphrase you, it's a teamwork that's done by doctors, the clinical pharmacists, and the nurses. Give
Absolutely.
oral instruction, which has to be very clear to the patient's parents. You also need to give written handouts so that they have something to refer with them. Finally, you have to demonstrate to them in the hospital and take re-demonstrations so to ensure that they have understood well what has been explained. And lastly, about the drug interactions, you need to tell them, and also therapeutic monitoring of certain medications if it's required for the child, that needs to be explained. Am I right, Dr. Tripathi?
Absolutely. The food
Yes.
interaction, because
Yes.
these child will be on
Yeah.
milk based diet, and sometimes a milk based diet
Right.
can interact with the drug.
Yes. So thank you. Let's move on to our second round for today's panel. And I will be asking one question to each of our panelists. I would like them to be very, very brief. Maybe in one word, if you could give me an answer to a question that I ask, would be most helpful in the interest of time that we have left with us. So first, I would like to ask Chandrakala. Chandrakala, not with the policy or audit, but by changing a single behavior across the system, how would you like to prevent the incidence of infection among such patients? What would be that one behavioral change that could reduce infection?
Okay, one behavior that could reduce infection, it is a hand hygiene without any doubt, following WHO 6 steps, 5 movements at all the time, not only in BMT area, across the hospital. This is one single most method we can prevent the infection in the entire hospital.
Excellent. I think everybody would agree with that. Thank you, Chandrakala. Anisha,
Yes, ma'am.
what is one moment where you must stop being a junior nurse, pause the process, and speak up, even if everyone else seems confident?
Yes, ma'am. So that's really important. Chemotherapy administration with unsafe counts that's lead to infections, and it's leading a severe complication. So in this case, we are privileged. The nurses are privileged to stand forward and post the infusion and notify the physician and start neutropenic fever protocol as per the consultant.
Thank you for that, Anisha. Tika, for you, I would like to ask that from this case that we discussed today, how would you say that it is the system and not the nurse who's starting to fail? And how do we recognize it?
The movement neutropenic fever, instead of wait and watch, it should be act now.
Thank
If
you.
patient get
Yes.
fever, we should not, it is equal to emergency. We should not wait or watch like that. We can't think. We have to act something that time.
Okay. Next, my question is for Mrs. Shiny. Mrs. Shiny, what is one nursing system change that you would suggest for redesigning the system to avoid complications?
Yes, I would prepare a care pathway because I'll make it very clear everything, what the steps we need to follow, so that there will not be any doubt or missing of the steps. So, a care pathway would be my answer.
Absolutely. Most nursing administrators would agree, I guess, with this. And finally, coming to you, Dr. Tripathi, uh, what is one medication related risk that keeps you awake at night? And how would you redesign the system so a nurse or a doctor doesn't have to catch it at the last minute?
I would say two.
Okay.
The veno-occlusive disorders or diseases that we come across during transplants,
Okay.
which can cause DICs and can lead to liver failure, can lead to coagulation related complications. So
Okay.
excessive bleeding, etc., etc.
Mhm.
And second important thing is being aware of the drugs those are that your patient is
Mm.
on. At least being
Mm.
aware of why they are being given a drug, so that we eradicate the chance or take off the risk or the chance of any medication error for that sake.
Mm.
These are the two things I think which can transform the care.
Thank you, Dr. Tripathi. So, with that, we come to an end of our panel discussion. I want to thank all the panelists who come from diverse backgrounds with varied experience. I think all of them have given us very good insights into care of a patient, a pediatric patient who's receiving chemotherapy. How should we contribute to his care as a team? And I'm sure our audience has several questions for our panelists. So, Mr. Abdul, can you help us with the audience questions if we have any for the panelists?
Sure. So as of now, I couldn't see anything in the chat box. So I'm like, let's open the floor for discussion. I guess there's a hand
Yes.
raised, Jyoti. Yes, please. You can shoot your question.
Can you hear me?
Yes,
Yes.
yes, very well. Yes, please.
Okay. So first and foremost, hearty congratulations. All of you have done a fantastic job, and the multidisciplinary panel, I think, helped so much more. The only thing, because I need to jump to another meeting, the only thing I wanted to mention is well done. And secondly, two important things I wanted to introduce, especially when the patients go home, is one is teaching them red flag signs. Very important, big bold letters that they know. And the second is escalation matrix, whom they contact for what problems. These are the only two things I wanted to say. Thank you so much. And it was a very, very educative, informative discussion. Thank you, Sonali ma'am. Thank you.
Thank you, Mrs.
Thank
Jyoti.
you.
These are very useful inputs. Thank you.
Thank you.
Thank you. Anybody else who would like to add or suggest few things like Mrs. Jyoti had?
Madam Shalini, you wanted to speak something? If you have doubts or you want to suggest something, you want to share something? Okay. Okay, so I guess
Very
it was
well
more of,
within time.
yes,
Yes.
we are within time, and I guess it was all well taken, points by everyone. I just have only one question to Dr. Priyank. Um, as a clinical pharmacologist, I'm sure that you are with one of the leading cancer organization of India, HCG. So I just wanted only your suggestion as a novice nurse, as a nurse who's trying to get into oncology setup. What would be the best advice for a junior nurse to understand the nuances of chemotherapy, though it has been taught in pharmacology as one subject for nurses, but it is not in depth. We don't learn, or it is not taught like what exactly the chemotherapeutics are and how it works and all those things. So, what would be a better, advice for any junior nurse who wants to excel into oncology nursing and better learn about the chemotherapeutics or the agents whatsoever we call it, we were trying to administer for the patient?
Um, Two very simple advice. First, know your drugs. See, there are only handful of drugs that if you are a nurse working in a cancer center dedicatedly. I mean, I'm sure you'll be assigned with a specific role. Either you are in your day chemotherapy areas, you are in your inpatient chemotherapy areas, or you are a BMT or any kind of transplant for that sake, any kind of transplant nurse, you are ICU nurse, or you're a pediatric nurse. You have only handful of drugs to deal with. When I say handful, maybe about 20, 30 common drugs to deal with, right? Make an effort to know your drug. Trust me, even if you take one protocol a day, one protocol or two protocols a week. Don't burden yourself because there's a lot of work. I mean, um, uh, uh, I'm sure we all, for, from the nursing perspective, we talk about ratios. We look at 1:7, 1:5, 1:4. Sometimes this 1:4, 1:5. Depends on what kind of those 4 or 5 patients you have. They can be those 4 or 5 patients which require utmost attention, which possibly require 1:1 or 1:2 kind of an attention, right? But the ratios are ratios. I mean, you have been given a ward which has a specific ratio, right? So you may not get time to read when you are at work, possibly. But if you get, please do that. Otherwise, pick two protocols a week, read about it, and trust me, by the end of a month, or by the end of 2 months, or by the end of 3 months, you yourself will start understanding why something is given to whom, what kind of problems that your patient may face, what kind of advice that you should give to your patient in terms of the counseling, one drug specific or your protocol specific counseling, whenever. And this way, you are contributing a big deal in minimizing a lot of medication errors, right? If there is a medication swap, if there is a wrong prescribing, you know you'll easily be able to identify it, because you know what drug your patient is on, why is he on, right? Second most important thing is ask questions, right? If you have anything, any doubt, any confusion, I think one of our co-panelists was mentioning about looking at the labs. It's very important. I mean, if you see that the counts are low, but still the chemotherapy is prescribed to the patient, please ask the question why, right? I mean, this is what I advise the students, observers, juniors, colleagues, peers, whomever I get a chance to talk to. Ask questions. I'm sure you'll have a lot of questions whenever you are, or whenever we take care of a patient. We have a lot of questions, a lot of which we try to answer ourselves, uh, a lot of which we would require inputs from our fellow healthcare professionals. So create that environment within your unit, within your hospital or ecosystem, that we ask questions to each other. That solves everything, and helps a lot in learning the subject per se.
What I just want to add something, Diane, for since you asked this question, I was listening very carefully to what Dr. Tripathi is saying. Probably having CNE sessions for our nurses on most common protocols that are followed today in hospitals would help, and those sessions could be led either by doctors or the clinical pharmacists like Dr. Tripathi. So that they get insights, as he rightly said, with the workloads and all, they hardly have time to read, and sometimes even if there's time, they're really very tired with their work. So it might help smaller sessions, not very longer ones, might help to improve their knowledge. And I think next part, what he said is excellent. Ask questions. Yeah.
Very true.
Yeah. Thank you.
Thank you. Thank you.
Thank you,
Thank you
madam.
for that beautiful, points and summing up also, Sonali ma'am. Thank you
Yeah.
so much. And yeah, so we are right on time. And with my last question, to the nurse administrator, I'm sure Madam Shaini has, extensive years of experience, more than 20, 25 years. Madam Shaini, like, what is your, uh, you know, one small advice to any nurse uh, who joins any organization and want to excel in nursing, because we are trying to collaborate now, we are along with AYNA, so I'm sure that we should also give an insight for a small little nurses there to understand, because when we try to finish our college or school of nursing program and we come out, and it's all more fancy for us, we think, yeah, it's more easy, right? But when we come into clinical, the reality is very different. So what would be your one advice,
To
apart from
excel.
CNE, apart from
Yeah.
CNE, apart from training? So what would be one, kind of take-home message which can be carried along, probably whatever the age or whatever the experience they get. So that one advice which could stay with them forever, be till they want to, excel a nurse.
Absolutely. So, if you want to be excelling, be patient centric. Patient is the reason why we are here. As long as you want to practice as a nurse, patient is going to be with us. So, patient centric, patient focused care will make you an excellent nurse, and patient will teach you many things.
Very true.
right? So be patient-centric. Patient is the reason why we are here. Like I remember what Mahatma Ji said one day, right? Patient customer is not the interruption, but they are the reason why we exist. So if you focus and if you are patient-centric, you will excel. No doubt about that.
Wonderful, lovely. Thank you so much for that, wonderful show-stopping advice. So thank you so much, Madam Shiny. And yeah, with this, we come to a closure of today's Empire Hour for this particular month and from Chapter Karnataka. And to sum up, a big thanks to our mentor, Dr. Jyoti Clara, who's our chairperson and the president for the 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 south wing or south zone, yes, and along with that, Dr. Sonali Jadhav, who was our moderator for the day's session today, and who spent much enough time to understand, to discuss with all of us, to understand, to put us together, and help us put a beautiful show today. And thank you to all the panelists, Dr. Priyank, Dr. Shaini, Chandrakala, and our Saintika and Anisha. Thank you so much, and more power to you, Anisha and Sayantika. Very well presented. We couldn't believe that you were all junior nurses, but probably we are just using a word called junior nurses. You were absolutely outstanding. The confidence, I would definitely want to read that particular appreciation came from Tanka ma'am's chat. So she has just dropped it saying that young nurses soaking confidently. Well done. So I guess this is a great word of appreciation for you all. I'm not sure how far you or how you know whether you all know Tanka madam. Uh, Ma'am is all about energy. Ma'am is all about knowledge. That's what we believe in as people from nursing fraternity. So I'm sure that this particular appreciation will take you long a journey in nursing, and your existence here as a panelist is showing that what great work you have done in your organization. Right, so that's the reason why you are here as a panelist, so confidently presenting, what you have done. So thank you so much, and keep those confidence, and keep shining. And with this particular note, thank you so much to all my team members of ANEI Karnataka, and all the participants, and all the team members and delegates, and seniors who have connected here, taking your time out to hear to us and to take home with lots of learning. Thank you so much. Have a wonderful evening. Thank you all.
Thank you.
Good evening to all. Bye.
Good evening. Bye-bye.
Bye-bye, everyone.
Bye.
Thank you.
Bye.